So welcome back to another edition of the Heart to Heart podcast. And my guest today is Dr. Ben Sessa. Dr. Ben Sessa is a consultant psychiatrist. He's also a psychedelic psychotherapist and is the chief medical officer of Awakn Life Sciences. So welcome to the show, Dr. Ben.
Hello, thank you very much for having me. It's a great pleasure to be here.
And you're in London, England today, correct?
I'm in Bristol, England today.
Oh, you're Bristol, England. Okay. Well, we're in London, Ontario here. So almost London to London. So is there anything else that you wanted to share about yourself before we get started, Ben?
Do you want a sort of potted life history of how I got to where I am? Would that be helpful? Or would you like to kind of ask me those things as we go along?
How about you start off just by maybe telling us how you got interested in psychedelics and maybe why you think and why you believe so much in them as a medicine.
Okay, so I qualified as a medical doctor, studying medicine and surgery, and then specialized in mental health and psychiatry, and then specialized in child and adolescent mental health. So I've always had a very strong lean towards developmental psychology and early childhood trauma and how those issues become adult mental health problems, and particularly addictions. And then in my teenage years, I had psychedelic experience, and I knew about the work in the 50s and 60s in psychiatry with psychedelics in the first wave. And then when I was at medical school and then later in training in psychiatry, I would always ask my tutors about that work in the 50s and 60s. None of them knew anything about it. They all thought I was crazy and what am I talking about? So I kind of decided to get involved and start bringing this to the attention of my generation of psychiatrists. And this was about 16, 17 years ago. And there were very few people involved at the time in the UK. In fact, I was the only doctor that was doing anything here. And then I met David Nutt, Professor David Nutt, who's a pharmacologist here, and started working in the research field in the last 15 years. And since then, I've been worked alongside or on or as a subject in studies with LSD and psilocybin and DMT and ketamine and MDMA. And then 5 years ago or so, started an MDMA study, which was the world's first MDMA study for addictions. And then in the last year, we started this company, Awakn Life Sciences, which no doubt we'll talk a little bit more about. But I think the main thing that's driven me towards this, the two main things, one is the observation of the lack of efficacy of current treatments in psychiatry and how they are failing our patients and are inefficient and ineffective and unsafe some of the time. And so it's that patient power, but it's also just what I've learned over the years through my immersion in the field of psychedelics about how powerful they can be. So I really do think that psychedelic medicine represents the greatest opportunity for, it's not just a psychedelic renaissance we're enjoying at the moment. I would say it's a psychiatric renaissance. I would say that we're in a position to radically reform the whole way in which we look at and study to carry out mental health care. And psychedelics have a really vital role to play in that. So there's so many ways, culturally, socially, medically, that interest me about this field. So I hope that's a little bit of an introduction.
No, that was perfect, and I feel the same way, Ben. We know that SSRIs are only effective for a certain group of people, and for people who don't know what SSRIs are, they're selective serotonin reuptake inhibitors, which are the most commonly prescribed medicine for basically all mental health disorders. Like, it's not necessarily just limited to depression, but also it's generally the mainstay treatment for anxiety, for PTSD as well. So, and it's unfortunate that, most people, don't actually respond very well to SSRIs. I mean, some people do, but it's fairly limited overall. And then, to your point, SSRIs came out. I mean, the first one came out, Prozac. I think it was 1980, and it was early 1980s anyway. So, we're talking now, 4 decades of using basically, the same medicine over and over. And so it's definitely time for a change. And on that note too, it's hard to talk about SSRIs without talking about, benzodiazepines, even though, they're completely different classes of medications, but those have also been, fairly commonly prescribed over the last 40 years. And we absolutely know that benzodiazepines can be very addictive, and in some instances can make anxiety worse just through withdrawal effects. And I have seen studies indicating that for PTSD, for example, it can actually worsen overall outcomes. So, I think that gravitating towards something new, a new medicine, is something that we should be doing, because we absolutely know now that the SSRIs are not effective for everyone, and we do have some evidence. Yes, a lot of it is preliminary, but we do have some randomized control trials and lots of evidence that psychedelic medicines can absolutely work. So I'm happy to hear that you feel the same way, and I'm happy to chat too about some of the trials that you've been doing. So if you don't mind, Ben, I know that you recently or fairly recently completed a trial on MDMA. Would you mind speaking about that?
Yeah, just before I get onto that though, just to pick up on the point you
Yeah.
made, I mean, it's not just benzodiazepines and SSRIs, it's every single class of psychotropic medicine that we use. It's the way in which they're used. They're used as maintenance therapies, daily maintenance therapies to suppress symptoms. If the patient can't sleep, we give them a hypnotic. If they're depressed, we give them an antidepressant. If their mood fluctuates, we give them a mood stabilizer. If they become mildly paranoid, we'll give them an antipsychotic. And we'll use antipsychotics in a broad spectrum way across multiple different conditions, way beyond psychosis as well. So it's not just that we're using all of these ineffective drugs, it's the way in which we're using them. We're not using them in a focused way to cure people. We're using them to paper over the cracks, to suppress symptoms, but not create a cure. So we have painted ourselves into a corner in biological psychiatry with this dependence upon daily maintenance medication, which doesn't get the patient 100% better, but it just makes them feel a bit better, but it doesn't cure them. So what psychedelics represent, cynics may look at it as, oh, look, here's the psychiatrists with yet another drug for us. But actually, psychedelics are the antithesis of current medical prescribing in psychiatry. People who are interested in psychedelic medicine, like myself, are interested because we don't like those other psychiatric drugs. The psychedelic medicine therapies are to come off other drugs. You will use them once, twice, three times, maybe more with ketamine, but generally it's a short, limited intervention, which is then curative, and you do not need long-term maintenance therapy. So it's a radical new paradigm for the way we do mental health. A much better analogy would be like surgery. You don't have multiple lifelong treatments for a broken leg, unless you're very unlucky. You go in, you have an intensive major piece of surgery, and then you're done, and you're fixed, and you're discharged, and you don't see that surgeon ever again. I want psychiatry to perform like orthopedic surgery. I want to bring people in, fix them, get them out, and never see them again. But what we have in psychiatry is this: we perform almost like palliative care doctors. We get alongside our patients for life, and we are patching them up and smoothing over the cracks and assisting them and helping them, but they never get better. And I believe there is a new way of doing psychiatry, and that psychedelics offer us the best opportunity. So it's really potentially not just about psychedelics. This is a revolution in psychiatry itself, the concept of psychedelic drug-assisted psychotherapy.
I really like what you said there, Ben. And just before you do talk about that study, I feel the exact same way, that we should be trying to cure or heal people instead of manage their symptoms. And I think the analogy with the broken leg was absolutely perfect. And that's exactly what SSRIs do, and what a lot of psychiatrists do these days, is that they're basically just making their patients dependent upon a medication that makes them feel a little bit better without going into any real deep healing. And I think that that's the big difference between the SSRIs and benzodiazepines compared to the psychedelic medicines, is that psychedelic medicines allow for a deeper level of healing where you feel like you don't need any medicine anymore. And that should be the goal when you start off, when you're trying to use psychedelics, is like, I'm going to use this for a short term because I believe in this medicine and I believe that it's going to help me heal, so that when I'm healed, I'm able to move forward without using any more medicines. Whereas in the model that we have now, it's all like, you need to be on this medication for the rest of your life. Like, that's what lots of patients are told all the time, is that you have a deficiency in serotonin, deficiency in some type of neurotransmitter, and then because of that, they're told you need this medication for the rest of your life. And they'll even in some ways compare it to like diabetes medication. They'll say, oh, you take your diabetes medication every day, you just need to take your mental health medication every day, which is incorrect. And yes, there's some people who need diabetes medication every day, but just like mental health, we can correct diabetes with exercise and with different things, so that we're not dependent on medication. And I think that with psychedelics, the level of healing is so deep that when you actually take these medicines and benefit from them and heal, you're less likely to be dependent upon them in the future. And I think that having less dependency itself is a major win in terms of mental health. Just knowing that you're not dependent upon a medicine to make you feel well is good for your overall mental health. So yeah, I don't want to belabor the point any further, but I certainly do agree with you on that point, Ben. But yeah, if you could come back and maybe just tell us a little bit about the study that was done on MDMA. I think it was published sometime in February of this year. That'd be wonderful.
Yes. So I've been interested in MDMA for a long time. I think it's a really, really useful medicine. I think if you were going to invent a medicine as an adjunct to trauma-focused psychotherapy, you'd come up with MDMA. It has all of the innate qualities that facilitate trauma-focused psychotherapy. And around about 5 years ago, I was talking with MAPS, Rick Doblin at MAPS, and the obvious thing to do would be to do a post-traumatic stress disorder study, because everyone was doing that with MDMA. And then we got a very lucky break in terms of a large donation. And so I decided I'm not going to do a MAP-sponsored PTSD study. We're going to do something completely different. And we're going to try do a new indication rather than PTSD. And at the time, I was working in adult addictions. Having moved on from child and adolescent psychiatry, I was part-time in both. And I wanted to choose a large public health problem that currently has very poor outcomes. And so alcohol use disorder was the obvious choice. It's a huge public health problem. It costs millions. It's very destructive. It's very difficult to treat. And current treatments are poor. Relapse rates are high. So it seemed, and crucially, it is underpinned by trauma. So I've always seen all of the addictions as essentially PTSD plus compound. Every patient that I've worked with in addictions, whether it's addictions to alcohol, benzos, opiates, cocaine, whatever, underpinning it is some kind of trauma, either big T trauma or little t trauma, but some kind of noxious childhood experience that is an impediment to recovery.
Can you give us a couple examples of that, Ben? Of the childhood trauma that you feel can fester into adulthood trauma?
Yeah, so as I said, as a child psychiatrist, I take a very developmental approach to everything. The concept of the attachment relationship, those early first 5 years of your life, or even the first 18 months, first pre-verbal years of your life, are absolutely crucial to the development of your healthy personality. If you are lucky enough to grow up in an environment in which you're praised and you're played with and you're told you're clever and smart and funny and beautiful and lovable, and you're intelligent and you're going to achieve, then all of these things will come to you, and you will grow with a personal identity of I'm a good, worthy person, and also a world narrative identity that people are good, people will help me, people are charitable, I can trust people, the world is a safe place, which indeed it is. If you are unlucky to have disruption to that attachment relationship, where you are maltreated or abused, then you develop these very negative narratives of self. I'm useless, I'm a failure, I'm worthless, I'm unlovable, I'm ugly, I'm stupid, I can't achieve, no one's ever going to love me. And also narratives about the world. People are dangerous, don't trust people. If they compliment me, they don't mean it. If they say they love me, they're lying. I've got to get the boot in first. There's something going on here. And once these narratives of self and world are embedded in these early years, they become very, very rigid indeed. Now, it's not fair to say completely fixed. If that was the case, I'd be out of a job. But very, very rigid and very difficult to shift. And believe it or not, most of our opinions about ourselves and the world, we learn in those first few years, and they stay for the rest of our lives. And it's difficult to shift them. And then in adulthood and in adolescence and adulthood, these then emerge into mental disorders of some kind. And I'm not a psychiatrist who's a big fan of psychiatric diagnosis. It doesn't really matter what you're going to get. You're going to get something. It may be OCD, it may be PTSD, it may be addictions, it may be anxiety, it may be depression, it may be an eating disorder, it may be a personality disorder. The end point, the end phenotypic psychiatric disorder in an adult is almost a red herring. What underpins it all is these disordered early years, which then split off and scatter into some kind of mental disorder. Of course, there are genetic factors that weigh you in one direction or another towards certain psychiatric disorders. But essentially what underpins most, if not all, psychiatric long-term disorders is some form of childhood trauma. Now, we sometimes talk about big T trauma, the stuff that hits the social services radar, like physical abuse and sexual abuse. But I always say, don't take your eye off the ball when it comes to emotional abuse and neglect. Those aspects which may seem more benign are incredibly and profoundly disturbing to the development of human personality. I don't love you. Your dad doesn't love you either. We didn't want a boy, we wanted a girl. That picture you just drew, that's rubbish. Anyone could have done that. You're the ugliest kid in the class. You know, why are you crying? You know, you're stupid. That sort of stuff is profoundly damaging to the development of personality. You know, no sexual abuse going on there, no physical abuse. That's emotional abuse. And it underpins all of these disorders. So the patients that we work with, yeah, many of them have big T trauma. They've grown up in institutional care. They've experienced physical abuse, sexual abuse, social services involved, etc. But when you dig a bit deeper, pretty much everybody, if they haven't had those big things, says, yeah, I had a lousy childhood. I don't think I was very loved. I wasn't really very wanted. And underpinning their entire personality is this sense of low self-esteem and low self-worth. And that's what then develops into mental disorder and becomes an impediment to recovery, because it's very hard to shift that. So I've had a very positive attachment. Someone came to me now and said, do you know what, Ben? You're not a nice guy. You're actually a horrible, mean, greedy, arrogant, awful man. Everyone hates you. The world is really dangerous. You mustn't trust people. Your friends don't really like you. If someone said that to me now, I wouldn't believe them. Why would I believe them? So why would my patients believe me when I try and tell them otherwise? And so this is what we're dealing with. We're dealing with rigid personality structures that have developed as a result of childhood trauma, big or small T trauma. And that's why so many mental disorders are so hard to shift, because you're asking a person to challenge the very fundamental roots of who they think they are and who they've always thought they are since a very early age. And just as I cannot believe that I'm an awful, terrible person, it's very hard for me to convince my patients to do otherwise. So what do? We cover them with patched up daily maintenance medications to blunt the edges. And they sort of work a bit, but they maintain those narratives. Now, the best, most effective, innovative, and creative piece of psychopharmacology of the last 75 years is the psychedelic medicines. And what they do is, more so than any other intervention in psychiatry, they defrag, rebrand, and reboot your entire central personality from the inside out, which gives you this very unique opportunity to completely rebrand yourself and re-challenge those narratives that have kept you held back. So no other medicine has the power to do this. And in combination with psychotherapy, this offers a much better outcome for patients, for full healing, like you say, rather than just maintenance therapy.
So, Ben, you said a lot there, and I really agree with you. But one thing I want to, just discuss a little bit further is, the childhood trauma, because we always associate trauma, the classic kind of trauma is like the soldier who's kind of gone to war kind of thing, and people do recognize trauma from like rape victims or sexual abuse and things like that. But I think that and those are devastatingly traumatic experiences that affect people. But I think that sometimes and I think this is what you were trying to say, but correct me if I'm wrong, is that sometimes we do push some other things to the wayside, like emotional abuse, verbal abuse, harshly criticizing children, like things like that really develop into mental disorders as an adult. And I think that that's the majority of people. Like, yes, there are some people who underwent some horrific experiences, whether it was physical abuse or sexual abuse, but I think that most people experience some type of childhood abuse in the form of verbal abuse or emotional abuse, or not getting any encouragement from their family. And I think that that translates into low self-esteem in adulthood. And I think that's something that's being discussed. And I'm not someone who babies my patients in any way whatsoever, but I do feel that there are patients out there who are being neglected and who do have real trauma, but it's not recognized as real trauma because their trauma is just their again, just, I use that word lightly, just their parents criticizing them, condemning them, making them feel sort of inadequate, as opposed to someone who was sexually or abused or physically abused. But we do need to recognize that that is really the mainstay of depression and anxiety these days, is that people who grew up in homes where there was very little encouragement and a lot of criticism. And I think that when you put someone down over and over again, it's really hard for them to build any self-confidence and to build any type of self-esteem. And without self-esteem and self-confidence, of course you're going to be you're going to be depressed, or you're going to develop anxiety. So very important point that you just made. And I think that a lot of people need to look at their childhood a lot closer, and when you do that, you may gain some awareness as to why you feel the way you do now as an adult. And I feel that that we have failed the system and failed some patients in some ways, because we're not recognizing that they have emotional abuse that needs to be deeply healed, and that shouldn't be managed just with SSRIs and treating the symptoms.
Yeah, I mean, I would go one further, Mike. I would say, in my experience, having worked for 10 or 15 years with abused children, the emotional abuse is more damaging than physical or sexual abuse. If you have a stable, secure attachment, you would be able to weather one or two discrete episodes of physical or sexual abuse far better than a person who's not been physically or sexually abused in any way, but has had years and years and years of pre-verbal or under fives emotional abuse. So the emotional abuse is more damaging, because it's those comments and lack of validation of positive self that really destroy the personality more so than other forms of trauma. And of course, you then adult experiences happen, like combat PTSD, and combat PTSD, it's interesting. A lot of people within the United States think of PTSD as only combat PTSD so often. I think because America has a very strong emphasis on military activities, and much more so than most European countries. But I've worked all my life with PTSD. I must have seen only 24 cases of combat PTSD. So PTSD is not about combat PTSD. It tends to be about long-term damage to self. Now, so for example, you take 100 people into battle, 95, and expose them all to the most horrific experiences. 95 of them will come back fine, resilient to what they've been through. 5 of them will come back with PTSD. When you then look at those 5 that came back with PTSD, they all saw the same stuff. You look at the 5 that came back with PTSD, hey presto, they were all abused or maltreated as children. So that early childhood trauma of neglect or other forms of trauma is a huge risk factor and vulnerability factor for later adulthood problems. So those early years are crucial. That's where you learn your bedrock of personality and self, which is then protective. And there's not enough research done on resilience against what should be traumatic. We don't spend enough time looking at those 95 who didn't get PTSD, because that's really interesting. Why didn't they? How come they were exposed to all horrible things and they came out fine? And so,
sometimes
yeah, you're absolutely
even better.
right. And
so
what it really does come down to the and I know that child psychiatrists, they bang on about 2 things more than anything else. One is attachment, and second is boundaries. That's it's so I think what sort of doctor are you, Mike?
I'm a family doctor, but I primarily do cannabis medicine, and I do a lot of work with ketamine as well, and then I also do some general family practice stuff and some hormone stuff as well.
So I think all psychiatrists should do at least 5 years of child and adolescent psychiatry, and I think it's having this very good understanding of developmental psychopathology is so crucial to the understanding of adult mental disorder. So we've certainly labored that point, haven't we?
Yes, but I think it's a point that we needed to get out there, because I think a lot of people need to hear that. And I think that as medical professionals, we need to do a better job of recognizing emotional abuse in children, and understanding that that is the reason why people are drinking excessively now. And if I sort of think about people in my life who drink excessively, a lot of them didn't have very good childhoods, and I think, and I imagine that a lot of people who are battling alcohol abuse, or even just battling depression, don't really look at their own childhood. They kind of think that that's phooey, or it's not something that is grounded in science. But the reality is that when you look back at things, and you look back at the people who are who have addictions and severe mental health disorders as an adults, a lot of it stems from their childhood. So I think it's just an incredibly important point. But one thing,
offending behavior. We could empty the prisons. We could half empty the prisons and hospitals tomorrow by providing better care for single mothers with children under 5. It would just halve all the rates of crime and mental disorder by improving attachment relationships. We could empty the other half by changing drug policy and regulating all drugs. So we got some challenges ahead of us, don't we?
We definitely do. But I think that, luckily we're talking about psychedelics today, and more people are interested in using them. So hopefully, we can help those people. But one thing too that I wanted to mention, or ask you about too, Ben, is, you mentioned that, a lot of these people who experience these traumatic experiences, 95 out of 100 who go into combat will come back fine. There's something also called post-traumatic growth. It's something that I've studied a little bit in the past. I actually need to kind of update myself on the most recent literature on it. I haven't studied it in a little bit now, but that basically indicates that, some people, they're not only resilient to what happens, meaning, resiliency basically just means that, you're going back to at least your previous function after you've had this traumatic experience. But some people actually get stronger from it. And we should really be looking at, those types of people, and why, and looking at their characteristics, and like, why are these people, thriving from something that has caused trauma in other people. And I'm not sure if you've have done much research on post-traumatic growth, but do you have any insight as to why some people actually get stronger from certain traumatic experiences?
Yeah, this is a really tricky one for me, because when I hear that kind of statement, it reminds me of that very damaging statement of tough love is a good way to grow strength and personality. And that takes us back to hitting kids as a good way of making them stronger. It's not. The very, very best way of making kids stronger is to cuddle them and to kiss them and to praise them and to play with them and to tell them they're great, not treat them rough to make them strong. And even the classic, that does not kill me makes me stronger. I don't really believe that's true. I think the very strongest people are the people who have not had adverse experiences. And you're right, there is a certain cohort for whom adverse experiences can result in growth. But we mustn't romanticize that idea. For the vast majority of people, adverse experiences have poor outcomes. And I think there's a danger in romanticizing the idea that you can grow from painful experiences.
I agree with you too.
And there's right, and more research is needed. But let's keep the message that adverse experiences are not good for people, and positive and secure experiences are what we should be striving for.
Yeah, there was, when you were saying that, there was, I was just thinking in my head, there was a book I read about 10 years ago now, probably exactly, called Hold On to Your Kids by Gabor Mate. And, he indicated that, like, the worst thing you can do when, your child is like a baby is crying is to, try to leave them alone, to sort of like toughen them up. Like he said that, what you should do is you should go console the baby if they're crying, and that will lead to better outcomes as an adult or as in the future. Whereas, a lot of people now, I mean, not everyone, but there are, certain groups of people who think that, you just need to let your kid cry, and then, they'll kind of toughen up, and eventually they'll stop crying, and that's sort of the way to do it. So, I definitely agree with you on that. And I know we only have about 20 minutes left, and we haven't really touched too much on the psychedelics yet.
We barely touched on psychedelics.
But that's okay though, because everything we've talked about so far has been incredibly, incredibly important. I think, recognizing childhood trauma and the fact that, emotional abuse is very, very real is something that, we need to discuss. So I'm happy that we've taken a lot of time on that. But, just coming back to Awakn and the psychedelics.
One of the dangers of
Sorry, go ahead.
It's one of the dangers of talking to a child psychiatrist. If you talk to a child psychiatrist, you're gonna get an earful on attachment. That's how it goes. But
well, next time I'll book a 3-hour podcast with you. So coming back to the psychedelics, so there's a few different ones that people are using out there these days, and again, psychedelics is sometimes some medicines get misgrouped into that. So, ketamine, again, can be incredibly effective. We'll chat about it. It can be good for treatment-resistant depression, anxiety, PTSD, alcohol use disorder. But, ketamine technically is not a psychedelic. It's an anesthetic. And then MDMA is sort of a strange one too, because it also, gets grouped into psychedelics, and, certainly does give a psychedelic-like experience, but technically it is an amphetamine. Is that correct?
It's an entactogen. So my feeling on this, Mike, is again, I don't like words and categories. We talk about what we call the classic psychedelics, and these are the serotonin 2A partial agonists like LSD, psilocybin, DMT, and mescaline. And those are, by definition, if you want to call it a definition, classic psychedelics. And then we've got groups like the entactogens, of which MDMA is the most common, but also MDA and the 2C series and MMDA and these a lot of the work that those phenethylamines that Sasha worked with. And then we've got groups like the dissociative anesthetics with ketamine and nitrous oxide being another one. And then there's things like ibogaine, which is a completely different mode of action, and salvia, and even tetrahydrocannabinol at high doses without CBD. I think this term psychedelic can be broadened, okay, especially in the clinical context. I think if we want to be a purist about it, we can't call MDMA a psychedelic, and we can't call ketamine a psychedelic. But if we're talking about these as clinical tools, the similarities between psilocybin, MDMA, and ketamine are far greater than their differences. Now, I'm not so naive as to say they are all the same. I have, you know, and any of us with subjective experience of these medicines knows that they're very different medicines. But in the context of a clinical setting, in which you have preparation sessions, a drug-assisted session, and integration sessions, and you're using it as a tool, as an adjunct to psychotherapy, then whether it's ketamine, psilocybin, or MDMA, the similarities are much greater than their differences. And so I'm quite happy to think of MDMA as a psychedelic with a small p, or ketamine as a psychedelic with a small p. And certainly in the context of a clinical psychedelic, because what they all have in common in different ways, and certainly through different neurobiology, what they all have in common is the creation of a altered state of consciousness, which allows you to tackle these rigid narratives in ways that you can't do without them. And when in combination with psychotherapy, that allows you to overcome these impediments to recovery that have been in your way your whole life. So sure, we can put things into boxes and call some things classical psychedelics with a capital P, and say MDMA and ketamine aren't those, fine. But in the context of the clinical setting, I think the similarities are much greater. And I think that as we move through this in the coming years, the next 5, 10, 15 years, I think we're actually almost going to see a dissolution of the word psychedelic to some extent. And we're going to see all of these tools will be used interchangeably for all psychiatric indications. And what we've seen over the last 10, 15 years is a certain pigeonholing, with obviously MDMA moving towards trauma-based disorders like PTSD and now addictions, and psilocybin being used for anxiety type-based disorders, and ketamine for primarily treatment-resistant depression initially, but then, like you say, broadening in terms of ketamine-assisted psychotherapy. What we're going to have 5, 10, 15 years from now is every single one of these different drugs being used for every single psychedelic, psychiatric condition. Because the way I see this going, any condition in mental health that responds to psychotherapy will respond even better to psychedelic-assisted psychotherapy with any compound, any of them. I would make that broad statement. So, and when we say any condition in psychiatry that responds to psychotherapy, that's every condition in psychiatry. Everything from schizophrenia to eating disorders to personality disorders to depression, anxiety, PTSD, addictions. There are psychotherapy programs for it. So I do see that we're going to be less pigeonholing ourselves, either in terms of psychiatric indications or in terms of the compound that we use as an adjunct to psychotherapy for the treatment of those indications. And indeed, we're going to do away with the diagnoses altogether. You know, I've been a psychiatrist for 25, 30 years. I've never met a patient with depression or anxiety or personality disorder or an addiction. I've met thousands of people with their unique idiosyncratic cluster of selfness, which is only them. And we can attempt to pigeonhole them with our diagnostic manuals, and we go crazy with these diagnostic manuals because we have to give something a name. But actually, they're all individual people. And one of the things that's so beautiful about psychedelics is they foster and engender the necessity for bespoke treatment in patients. You can't put people in boxes when you've just completely smashed to smithereens their entire sense of self and narratives. There's no gravity, there's no up and down or left and right or in or out or dark or white or matter or body or anything. When all of that's gone, there's no room for categorical diagnoses and boxes. So I think that we mustn't get too tied down with what we call these things. These are tools as adjuncts to psychotherapy. And yeah, we've started to fall into these kind of pigeonholes, but I'm hoping we're going to come back out of those pigeonholes and start using all of these compounds for all things, because I do think they will all work for all conditions once we get that way.
And do you think, Ben, that, you know, the major underlying reason why these medicines work so well is because of the dissolution of the ego? Is that, you know, the main reason why I feel these medicines work so well?
Well, that's the dissolution of the ego is more in the classical psychedelics. So
Right.
MDMA doesn't significantly dissolve the ego, or at all, indeed. And ketamine, it's very hard to explain the subjective effects of ketamine in
Yeah,
terms
the
of ego
mechanism of
dissolution.
action of ketamine is a rabbit hole that you can that you can study for a long time.
I mean, I think I see the ketamine state as it's the most extraordinary experience, because ego is maintained so strongly, but everything else falls apart. That's what's so weird about ketamine. So with say a classic psychedelic like LSD or psilocybin, it's like everything dissolves, including self. Ketamine, self is preserved, but everything is dissolved around it. And you can sit there and go, oh, look, there's no gravity, there's no up, there's no down, there's no in, there's no out. Everything's been reduced to a Tron-like world of qubits and pixels, but I'm here watching it all normal. Me, Ben, myself is unchanged, but everything else around has fallen apart. So it's a really weird sense of ego dissolution on the ketamine state. In this, and that's why, you know, as a dissociative, that's how it's kind of defined. It's an outer body type experience in which yourself is preserved, but that's very valuable clinically, because everything is reduced to a flat single plane, whereby, you know, the sound coming out of the speakers of your hi-fi has no greater significance than your past memory of child sexual abuse. They're all equally leveled. And so it is a form of ego dissolution in a way. And it's certainly a peak experience. And what's crucial about psychedelics is what we do with that material as we come out and we rebuild. Because when we've broken down those narratives to zero, it's then which labels do we hang back on ourselves when we come back?
And that's the difference between
crucially,
psychedelics and SSRIs. But sorry, go ahead, Ben.
oh yeah, I mean, because, well, SSRIs are just a totally different mode of action altogether. I mean, SSRIs just simply, you know, help to flatten your mood extremes, really, which can be helpful. You know, I'm certainly not one of these psychiatrists who is completely damning of all traditional pharmacology by any means, you know, because that's not helpful either. There are certainly plenty of cases in psychiatry that do respond to traditional pharmacological agents. Long-term treatment of paranoid schizophrenia with antipsychotics is a lifesaver. You know, it is kind of analogous to diabetes in many cases. I think it's way overprescribed and the doses are far too high, and there's a massive lack of psychotherapy and social inputs for people with chronic schizophrenia. But there are cases in which traditional psychiatric medications are very useful. SSRIs even. In short-term moderate to severe depression, there is a place for SSRIs. The problem that we have is primary care overprescribing of SSRIs and lack of monitoring by experts with psychopharmacology experience. I spend far more time as a psychiatrist, traditional psychiatrist, not a psychedelic psychiatrist, but as a traditional psychiatrist, taking people off medicines than I do putting them on. They come into the clinic on a host of stuff that people have put them on that they just don't need. And we spend a lot more time bringing people right back down to the barest minimum. So I think there's just a general lack of good psychopharmacology understanding and experience amongst many doctors and psychiatrists. But, you know, this is what we're blowing out of the water with psychedelics, because we don't really need any of them. If we can actually heal the person with a piece of focused, efficient, effective, fast, safe psychotherapy with these drugs as adjuncts for some of the sessions, then they don't need the maintenance therapy going onwards. We've mended their broken leg. They're not walking around on a broken leg taking painkillers.
And to your point, Ben, like some of these trials that have been done with MDMA and with ketamine, I mean, the people are only having, you know, 2 to 3 sessions, and sometimes, you know, then after even, you know, that many sessions, they no longer meet the criteria for PTSD, you know, which is crazy.
Absolutely.
So, you know, I think that's important for people to know that, you know, when you, like, when you take psychedelics, you're really trying to fix the problem, fix the root problem. Whereas, you know, when you're taking some traditional pharmacology medications you know, such as SSRIs, you know, you're not going to get that sort of deep healing at the level that you would get with psychedelics. And I think that's, you know, something that people are more interested in. I mean, they would rather, I think, have, you know, take something, you know, 3 times with the help of a psychotherapist, knowing that, you know, this can be more effective than, say, taking something every day for the rest of their life.
No, absolutely. And I mean, and the analogy is mending that broken leg. You know, when you break your leg, you go to a surgeon, you have a very expensive and intensive piece of work, a surgical operation. They mend it, and then you're better. They don't just half mend it or not even mend it at all and then expect you to hobble around but just take painkillers all your life. You get it fixed and you're better. And that's why it's this, that's a good analogy for what psychedelics are. It's an upfront, intensive piece of singular work that gets you better, and then you don't need to have maintenance therapy. But I want to talk a little bit about Awakn, if I can.
Sure. So, yes, please,
Yeah,
go ahead.
so, you know, so 15 years working in academic psychedelics has been a lot of fun, but it's all been very lab-based, research-based, small groups of people, small cohorts of research subjects. It's really exciting that in the last few years we're moving away from that, and we're moving into actually the development of healthcare systems for more people. And so a year ago we started this company Awakn, and what we're doing here is delivering a new form of mental health care to the masses. And we're doing this through both development and delivery. So we are doing research to see MDMA and ketamine licensed as approved medicines to treat alcohol use disorder. We're also developing new chemical entities. We're working on a shorter acting entactogen, so an MDMA-like molecule, but that could be delivered within, say, 1 to 3 hours or 2 to 4 hours, as opposed to sort of 6 to 8 hours, which will make it a lot more clinically deliverable and therefore more affordable and therefore better for public health. So we have this research arm and we have this delivery arm, which is the clinics. And, you know, there's a lot of psychedelic startups that are doing molecule development or training or drug approval. But there are very few, in fact, there's only one real competitor that we have, and that's Field Trips, who are actually building clinics. And that's what we're doing at Awakn. We are physically building bricks and mortar clinics, and we're opening 2 clinics this side of Christmas, Bristol and London. And we aim to open 15 to 20 clinics in the next 4 to 5 years throughout the UK and Europe, and into the States as well. So what we're very keen on doing is being the high street presence for the delivery of psychedelic therapies. Now, we're starting with ketamine because that's all we have. It's the only licensed drug with psychedelic type effects that we can use in combination with psychotherapy. But we're not a ketamine infusion service. That, as you know, the vast majority of people using ketamine are simply infusing ketamine as an antidepressant with little or no psychotherapy. We're branding ourselves as a psychedelic psychotherapy treatment service. Ketamine now, MDMA and psilocybin coming soon. So the point is that we establish ourselves as a psychedelic therapy service, and it is only ketamine that we have at the moment. We're also researching other compounds, but ketamine's the only one for treatment. But the really important thing is it's about the psychotherapy. That's how people get cured for mental disorders, psychotherapy. And psychotherapy is a very broad term. And the drugs are an adjunct to that. So the other thing about what we're trying to do is we want to see this for the masses. We want to see this for the free public healthcare system. And in the UK, we have the NHS, which is an excellent organization. And we want to work with the NHS and with insurance companies to make this accessible to all and not stay within the realms of only private medicine.
Excellent. Yeah, I mean, I think that, you know, the work that you're doing at Awakn Life Sciences is incredible, and it's work that needs to be done, and I think it'll be very, very, you know, well received. I mean, I prescribe ketamine at my clinic, and I was actually just published for a study doing psychedelic assisted ketamine therapy about a week or two ago, and you know, we had incredible results. There's only 10 patients in our study, but their PHQ 9 scores, which is, you know, sort of the classic standard measurement for depression, there it was down by almost 50%, you know, and this was after, like, you know, one session or two sessions for some people. So, you know, you don't have to, again, you know, use a lifelong medicine. You can use a medicine like ketamine, like they're using at Awakn, and absolutely heal yourself much quicker. And, you know, maybe it's not going to be one session, you know, it might be 3 sessions, maybe it'll be 10 sessions, you know, spread out over some time, because, you know, different people have different levels of trauma, and, you know, the more trauma you have, you know, possibly, you know, the more work that you'll need on that. Just like if you have, you know, a broken leg, you know, some people, you know, only break their leg, you know, slightly. Some people really, you know, break their leg. So it's definitely, you know, something that that people should be aware of, and to know that, you know, there are medicines, psychedelics out there that can help you heal and not just manage your symptoms. So Ben, yeah, on that note, we're basically out of time, but, you know, I really enjoyed our conversation today. You know, you shared so much information that I think a lot of, you know, listeners will really appreciate. I know that I'm going to have to go back over this podcast myself and re-listen to it. But, you know, I'm sure people want to follow you online. So where can they learn more about Awakn? Where can they learn more about you? And where can they, you know, learn more about the information that you're putting out?
Yeah, well, it's been a tremendous pleasure talking to you, Mike. Thank you very much for this opportunity, and I'm glad that we've veered away from psychedelics, because, you know, and we've talked more broadly about mental disorder and lifelong unremitting mental disorder and the developmental roots of it, and the inefficiencies and lack of efficacy in current treatments. I think those are subjects that have to be discussed when we talk about psychedelics, because that's why we're where we are with psychedelics, because we need them now. We crucially need them to reform the way we care for people with mental disorder. So AWKNLifeSciences.com is our website for the Awakn, all the Awakn services. My own website, drsessa.com, DRSESSA.com, where all of my papers and media stuff is, and videos and TV stuff, and all the books as well, because I've done a number of books as well on the subject. So you can go to my website and get it all there. But it is great talking to you, Mike. Thank you very much for this conversation.
Well, thank you so much for coming on, Ben. I know that people are gonna, you know, be asking me to have you back on. So, you know, maybe we'll do round 2 in the future. So thanks again.
Excellent. Thanks very much, and good luck with it.